Could everybody please take their seats? We're going to get started with our afternoon session. Just waiting for a few more people to get settled in the back. Okay. My travel buddy, my best friend, words that were used by Miss Wanda Irving to describe her daughter, Lieutenant Commander Dr. Shalon Irving. Can we please now prepare our hearts and our minds to hear what Miss Irving has to tell us about how she got to this place of raising Soleil.
Well, they've got this one on me, so can you hear me now? Let's see, move it up a little bit. Thank you for the opportunity to address you today. It's truly an honor. I've been thinking a lot about death lately, not in a morbid or obsessive way, but with the awareness that it is life's certainties, possibly the only certainty. Thus, it doesn't scare me or cause me any angst. Instead, my recent thoughts on the topic have focused on making sure I live my truth each and every day, so that when the certainty of death presents itself, I have no regrets. And I'm left with nothing undone or unsaid. This excerpt was one on the first page of a journal written April 20th, 2016. Let me paint you a picture of the person who wrote that excerpt. She was exceptional in every way. Too many ways for me to even adequately portray here. She was smart. So smart that she skipped 2 grades before high school. By the time she was 25 years old, she was a college professor. After earning a Master's of Science degree, plus a dual-titled PhD in sociology and gerontology, the first student to do so at Purdue University, and both summa cum laude. She later went on to earn a master's degree of public health from Johns Hopkins, also summa cum laude. While doing that, she was weekend caregiver for her older brother, whom she just so adored. He was wheelchair-bound as a result of multiple sclerosis. She was a prolific writer. Not having much luck here. Okay. She was a prolific writer, a published author with numerous scientific articles to her credit. She had also made major contributions to several scientific books written by colleagues, and co-authored an introspective self-help book called Beautifully Bare and Undeniably You, which was published in 2018. She was fiercely protective as a friend. Okay. Okay. All right, a little technical difficulty here. How about we do it this way. Well, is there a tech in the audience? Should be a video. Thank you.
Hi, baby.
Julia. Julia. You guys are right there. Hi, baby. You come up there. Julia. Julia. Don't play. Supposed to play.
So the audio is not coming through, but the video is playing? Yeah. Okay. So the audio is turned up on your computer too already? So it's just not playing. All right. Let me take a look.
Okay. I'll go on. Shalon was amazing. She was funny, and her smile was luminous, and her melodic laughter touched your heart. She had a way this is okay, I'll just push this, but there's still another video that needs to play. Okay. She had a way of making your day brighter and your load suddenly seem lighter. She lived her truth each and every day. She never lost sight of who she was and where she was going. Okay, this is going to... Okay, who's the gentleman up here this morning, the doctor who said, you know, he was so surprised that there was no problems? Okay, I've been trying that too. That's not working either. All right, let's try this. Sure, I'll just use this one. Okay. Okay. No, that's okay. She had an impressive career path that led her to her work as a lieutenant commander in the United States Public Health Service and a well-respected epidemiologist in the Center for Disease Control. Okay. We shared a love of travel. Over the course of 10 years, we had vacationed extensively throughout the Caribbean and traveled to over 20 foreign countries on 3 continents. She planned to share her love of travel right away with her child, who had a passport at 2 weeks old. Shalon had a passion for women's health. She was dedicated and committed to health equity. She saw inequity wherever it existed, was not afraid to call it by name, and worked hard to eliminate it. Doing good work was very important to her. She vowed to create a better earth. Okay, here we go again. This is, where did our tech person go? But no sound. Oh, and this was a great video, too. Oh, okay, well. So just go on. I'll just go on. There's just one more at the end. She worked tirelessly in several organizations to help young girls become the phenomenal woman that she knew there could be. Okay. She had just launched a consulting firm named Inclusivity Standard to empower first-generation college girls prepare for college and enable businesses and schools to embrace inclusivity. She was a devoted and proud mother of her exceptional little girl. She was a mother who was denied the opportunity to raise her daughter, the daughter she so desperately wanted, and the chance to live a long, long, rich life. I'm referring to Shalon Maureen Irving. Shalon was my middle child and my only surviving child. Shalon was a curious child, a phenomenal woman, and an amazing daughter. She was my heart. She was my best friend. She was my shiro. We talked every day, most times 5, 6 times a day. When we weren't together on the phone, we were texting or we were on Hangout. We got through the death of my sons and her brothers together. She was my strongest supporter when at 52 I went back to school to get my master's degree. She kept me from jumping off the ledge and going off on the deep end more than a few times, especially when it came to mastering statistics, which I still haven't mastered. This talk, and any time I talk about Shalon and share her story, it's a love letter to my daughter. I've given you a glimpse of who she was and how she lived, because she deserved that memory. Sadly, now I need to tell you how she died, because in honor of her memory, I hope we can save the lives of other women so they won't leave their parents and children before their time. What I want you to know as I tell Shalon's story is that I relive Shalon's death every time I share this story. It is painful, yes. It would be so much easier not to do this, to sidestep the fresh pain the few times a month that I tell the story. But if my daughter had to leave me, I've got to find some meaning in her death. It must help someone else, save someone else's daughter or sister or wife. That's what my daughter would have wanted. Shalon lived abundantly and joyfully. When she unexpectedly became pregnant at 36, the news only added to the fullness of her life. She was absolutely thrilled. We knew her pregnancy was high risk for her age. We often joked about her geriatric pregnancy. What wasn't funny, though, was that she was among the country's most vulnerable population. I never thought for a moment that as a black woman, my daughter was 243% more likely to die than a white woman from birth-related complications. From day one, Shalon did everything right. She exercised, she watched her diet, she attended every prenatal doctor's visit. She followed her OB's instructions to the letter. She felt good and she looked radiant. In a letter to her daughter, or child, the morning of her birth, Shalon wrote, "I am up and just sitting in my calming room meditating before we leave for the hospital. I can't believe that the next time I sit in this room, it will be as a mother with my beautiful, beautiful little one. I barely slept, either out of excitement or nervousness. Yet I'm not tired now, nor do I feel any nervousness. I am prepared. I am surrounded by love, both present and virtual, and I'm ready to meet this tiny human that I've been sharing space with for 37 weeks. It is inconceivable that someone so loving, so ready for motherhood, was cheated of that experience." There was nothing alarming about her delivery. It was textbook, with no complications. Everything went according to the very detailed birth plan she had prepared. Shalon welcomed her beautiful little girl, Soleil Mina Danielle, at 11:20 a.m. on January 3rd, 2017. Shalon saw Soleil as the perfect baby. Even with colic and RSV, Soleil was her greatest accomplishment. But she didn't have much time to celebrate her perfect new baby because she immediately started having pronounced health issues. 1 week after delivery, she developed a hematoma. She went to her doctor, who told her to wait and see. It'll take care of itself. He told her, don't worry. On the elevator down from the doctor's office, she ran into her obstetrician, who took her to her office and drained the hematoma. 1 week later, that wound was still not healing, so Shalon went back. She had also started experiencing other symptoms: rapidly elevating blood pressure, headaches, severe edema, decreased urine output, and unexplained weight gain. She knew, and I knew, that something was very, very wrong. Yet, despite frequent touches with her healthcare system during this period, her complaints were not adequately addressed. The medical personnel didn't look beyond the symptoms to see the danger lurking in the background. They attributed her symptoms to being a variation on the norm. She's fine, don't worry, and sent her home. I later found out that the doctor she saw had written in her chart, poor pain management, as if the fact she was there complaining of pain was her fault and she needed to learn how to manage her pain better. On January 24th, 2017, my beautiful daughter went to the doctor's office for the third time in 1 week. Twice that week, her blood pressure had been recorded at 174 over 118. Each time she was sent home. Tell me, with a blood pressure of 174 over 18, edema and swollen limbs, and unable to void, wouldn't you have put her in the hospital for observation? But instead, Shalon's concern and symptoms went unheard, unaddressed, and untreated for 2 weeks. And then the unthinkable. Shalon suffered a cardiac arrest at home on Tuesday night, January 24th, 2017, 21 days after the birth of her daughter. Outrageously, it was just 6 hours after returning home from visiting her medical provider, complaining of the same symptoms: severely high blood pressure, swollen limbs, failure to void, and a weight gain of 9 pounds in 7 days. 911 was called, and Shalon was transferred to the hospital, where we learned that complications from hypertension had led to the cardiac arrest, which deprived her brain of oxygen for a significant period of time. She was declared officially brain dead on Thursday, January 26th. There is nothing so heart-wrenching as seeing your child unconscious, connected to instruments that can only save her life, but cannot, or that can only say she's dying, but cannot save her life. Unable to open her eyes and tell you one last time that she loves you. Even with the dismal diagnosis, I could not let her go. I just could not. Thursday evening, my cousin came to the hospital with a medical directive she had found in Shalon's drawers and files. I had been keeping a bedside vigil at the hospital. In the directive, there was a paragraph that was handwritten by Shalon. The last line of that paragraph shattered my heart. She wrote, "Mommy, I will fight hard, but if there is no hope, please let me go." But I couldn't. I just couldn't. My bedside vigil continued. It wasn't until Friday morning when I saw a single tear roll down Shalon's cheek that I knew my daughter was ready to go. I sat by her bedside again that night, and the tears flowed. Then on Saturday morning, January 28th, 2017, at 8:59 a.m., with both her father and me at her bedside, life support was removed. 14 minutes later, she was gone. Imagine the many gerontology breakthroughs, health miracles, epidemiology victories, and social achievements that won't happen because Shalon's medical providers did not listen to her and adequately address her cries for help. This 36-year-old, beautiful, vibrant, brilliant woman of color who went to her healthcare workers again and again in distress and was dismissed each and every time. Even Shalon's many advantages, her BA in sociology, her 2 master's degrees, her dual-titled PhD, her CHES certification, her membership in the Epidemic Intelligence Service, her work as an epidemiologist, her gold-plated insurance, her rock-solid support system. None of that had been enough to ensure Shalon's survival. Shalon deserved better. I deserved better. Soleil deserved better. She deserved to know her mother. She deserved to have that amazing woman at her side as she grows up. Today, Soleil Mina Danielle is 26 months old. You would think she was 26, though, talk to her. And she's transitioning from a toddler to a little girl. Each day starts with a good morning to mommy's picture on the wall. In fact, Soleil smiles when she sees any picture with Shalon in it. And to me, it's like Shalon looking in the mirror, because Soleil's smile is every bit as brilliant as her mom's. I only wish Shalon were here raising Soleil and guiding her life. I never meant to be the one on the front lines, raising a spirited, which I can think of other words, little one who is ramping up her energy and excitement for the world. I thought these would be my quiet years. Instead, every day is filled with at least 152 why. I had planned to be that indulgent grandma on the sidelines, watching my daughter and granddaughter grow together. But since that can't happen, I will take Soleil as far as I can and give her the life that her mother would want for her. We will travel. She will learn to swim, go rock climbing, and camping. She will learn foreign languages. She thinks she's almost mastered English right now, but she's taking French too. She will learn to play the piano. Her grandfather has already bought her an electric piano and gives her lessons. She will continue with ballet lessons. She has her first recital in May. We'll go to Broadway shows and expand upon the shows we've already seen in Atlanta. Alvin Ailey, The Lion King, Disney, to include others that expose Soleil to the beauty and the talent in the world as she grows up. I know that Shalon's love will help me raise Soleil as the loyal, loving, bright, joyful individual her mother was, the kind of person who makes the world a better place and more equitable place to live. I will keep Shalon in my heart every day and every step of the way. Shalon was truly a remarkable woman, a phenomenal daughter, and the consummate professional. Though her legacy remains, the pain of losing her is still agonizing. Many days are still filled with excruciating and almost unbearable pain and unrelentless sadness. I can personally attest to the saying, the deeper the love, the stronger the grief. Nights were and still are the loneliest times for me, and many a night I still don't get to sleep. I miss my baby girl. I miss our conversations. I miss her laughter. I miss her smile. I miss her hugs. I miss her love. Always thinking of others, Shalon, always thinking of others, Shalon wrote a letter in the event of her death. It was written in 2014 and buried on her business computer. Strangely enough, my niece found it the evening after Shalon's memorial service. It was a beautiful letter. And at first I thought my niece had written it to ease my suffering. But I knew in my heart once I read the salutation that Shalon had written it. It was addressed to Beulah Bear, and no one on this earth calls me that except Shalon. I'll read you just the last paragraph. Mommy, I am sorry that I have left you. On the particular day that I am writing this, I have no idea how that may have occurred, but know that I would never choose to leave you. It troubles my heart deeply that you are grieving. I know it seems impossible right now, but please do not let this break you. I want you to be happy and smile. Little chance of that when I was reading that letter. I want you to know that I am being watched over by my brothers and Grandma, and that we will all be watching over you. Please try not to cry. Use your energy instead to feel my love through space and time. Nothing can break the bond we have, and you will forever be my mommy, and I your baby girl. I love you for always. Lon. Shalon, I hope you know that I'm using my energy to tell your story so that other mothers, other grandmothers, and their families will not have to suffer such a painful loss. There will never be another Shalon. She had such passion. She wanted so desperately to see the ending of health disparities. She was dedicated and committed to fighting on the front lines for racial equality and health equity. Yet she felt victim to that same inequity. Shalon's death has been called shameful, sad, senseless, a tragedy. The thing that is certain in my mind is that it was preventable, and that mere fact is so devastating. As I leave the stage today, I implore you not to think of Shalon as just another maternal mortality statistic, death number 113 in 2017, or one of the 60% of preventable deaths. Dr. Brian Yablong, an EIS colleague of Shalon and internist, said, Shalon was a kind, thoughtful, and principled woman. As a sociologist, she brought a unique and much-needed perspective to the science of epidemiology. She advised that we not get caught up in the numbers. She knew the numbers were important, but I'm adding to his letter. I don't want to say that. As a sociologist, she brought a unique and much-needed perspective to the science of epidemiology. She advised that we not get caught up in the science, that we forget the people behind the numbers. Her wisdom and moral compass were just two qualities that made Shalon an exceptional human being. If Shalon were here today, she would agree that statistics are important, but she would also caution you not to get so caught up in the data that the maternal mortality statistics that you forget that behind every number there is a face. The face of a woman who is loved, the face of a woman who has so much to offer the world, the face of a woman who will not get the opportunity to raise her baby. If you take that face and multiply it, that one statistic not only includes the faces of women who will be immeasurably mourned and forever missed, but also the families left devastated by her death. The babies, the other children, the mothers like me, the fathers, the husbands, the friends, the colleagues. The domino effect of that statistic is incomprehensible. So whenever you are tempted to think of maternal mortality statistics as just data or just numbers, put Shalon's face behind those numbers. And remember this video, that is if you can see it. Oh, okay, okay, all right. Well, the video addresses the fact that it's from one of her colleagues who said she was a junior colleague of Shalon's, and Shalon, when she went out on maternity leave, put her in charge of a project. And she told her, "I trust you inherently with this project." She was so insistent that the woman could do it, that she believed she could do it, and she's been doing a phenomenal job after Shalon left. So she has said that, I think that's fine. She wants you to know that everyone feels, I'm sorry. Shalon told her she trusts her inherently. Shalon would trust you inherently as well to continue the work, the heavy lifting, if you will, of shaping a better world that offers a healthier, more equitable future for her daughter and for all women. David Satcher, former U.S. Surgeon General, once said, "In order to eliminate disparities in health, we need leaders who care enough, know enough, will do enough, and are persistent enough." Shalon was one of those leaders. I hope there are a lot more of those leaders in this room today. Shalon always ended her emails with the following quote from Lily Walker: "If you are here to help me, then you're wasting your time. But if you come because your liberation is bound up in mine, then let's begin." I'd like to end with saying, if you are here to shed a tear for this grieving grandma and continue on with the status quo, then you're wasting your time and mine. But if you come because your liberation is bound up in mine and the fate of mothers, then let's begin to make a real difference. Thank you. Wave. Wave.
I sit down.
You sit down. I miss you.
Ms. Irving, we are so grateful to you. I have to get it together. we're so grateful to you for coming here and sharing your story. And I can assure you, I've been with people here in this audience for years, and you're in a room full of people who are committed to tackling this problem and getting this down to zero deaths, so this never has to happen again. I have for you, in memory of Lieutenant Commander Dr. Shalon Irving, your life will continue to motivate Michigan. And we are so grateful to you for what you've been doing. I've read some of the things that haunt you, and some of the things that, that have haunted you, such as wondering why she has to have become a statistic, and wondering why or thinking that she needed to create a postpartum plan to go along with her birth plan. And yes, we share your thought that the fourth trimester should be the postpartum era. So we just want to hand this to you, and when you look at it, just remember that those of us here in Michigan are working so hard, and we're so grateful to you for just sharing your story, and you have our commitment. Thank you so much. And so now I want Ms. Irving to, if you have a moment to please just listen to the rest of our afternoon. We are blessed to have with us Dr. Robert Sokol and Amy Zagman, who are going to now let you know what Michigan has been doing. So Amy is our executive director of our Michigan Council for Maternal and Child Health, and she's also the co-chair of our Mother Infant Health and Equity Collaborative. Dr. Sokol is Dean Emeritus and Distinguished Professor Emeritus of the Departments of Obstetrics and Gynecology and Physiology at the Wayne State University School of Medicine. He's also the co-chair of the MyAIM. And Dr. Sokol was my professor and is responsible for me. I don't know if he wants to claim that part, but certainly one of the reasons why the healthcare in Detroit and the care here in our state stands out is I just came back from our American College of Obstetricians and Gynecologists Congressional Leadership Conference. People know what we're doing here in Michigan, and we're just so grateful to have all of you here. So I'd like Dr. Sokol and Amy to come up and just share with everyone, including Ms. Irving, what we've been doing here in our state.
Get it back.
Are you okay with that? Do you want to have
Well, okay.
a little test?
Can you hear me?
Oh, this one.
Is that loud enough? Terrific. Well, I have the unenviable task of talking about some data and what's more, not talking about it from the front lines, but both Amy and I are going to do it from altitude and try to pull together a lot of what you heard today. There were excellent talks on the maternal mortality track today, and this will be something of a summary and at least my take on where we are and where we're going. Amy is going to be even at higher altitude because she's going to be talking about policy. Well, let's get started. Well, this comes as no surprise. We lose about 25 women a year from complications related to pregnancy or childbirth. Every woman who dies, for every woman who dies, there's about 100 more who suffer severe maternal morbidity, which can be life-threatening, infection, disease. So that's about 2,500 young mothers a year. That starts to sound like a substantial number. My problem with that is 25. And when we go and ask for grant support and stuff, we hear, well, it's only 25 women. And I get pissed off. It should be 0. This shows the split around the state. We've heard a lot about the regions, the prosperity regions today, and you can see that they're spread all over the state and are more or less proportional to, it looks like there's a lot more than southeast Michigan, but of course there are, most of the population of the state is in southeast Michigan. So that accounts for, in part, for that. But this is a statewide problem. It is somewhat different causes, different samples in different parts of the state. Well, what causes pregnancy-related deaths? You can see the biggies, and they're listed here. But there's something else I've decided that I think I need to point out on this slide. Take a look at the graph. The top line is the national average maternal mortality, pregnancy-related mortality. The bottom is Michigan. Our rate of maternal mortality is not higher than average. It is, in fact, we do not so badly. We could do better, and that's what one of my themes today is. But we don't have stupid practitioners. We don't have bad hospitals. We have somewhat lower maternal mortality than the rest of the country. It was thought to be somewhat higher, but a lot of that is pregnancy-associated, not related mortality. We are having a terrible problem with opioids. 1 in 5, approximately 1 in 5 deaths of women in pregnancy-associated, are now related to opioids. So there are many problems, and the statistics can sometimes help us understand what's going on, sometimes cover up issues and problems. The issue is not that we're higher or lower. You can see that when you look at morbidity, we really haven't had much of a decrease over the years. This goes out to 16, and I'll show you some more recent data. But you can see that it was pretty stable. In 16 is when we started my aim, and I'll show you in a minute what's happened. You can also see here that morbidity is substantially higher in blacks than in whites. And the same goes for mortality. Our ratio is about 3 to 1, as it is nationally. It's a disaster. This is probably the most important slide I'm going to show you. And this shows that about in our state, while nationally they say 60% is preventable, I do think our care is not so awful here. And every case here, all 66, were individually reviewed by our maternal mortality committees, one of the oldest in the country. We've been in business since 1950. And every one of them was looked at for preventability. And of all of the pregnancy-related deaths, about 44 were determined to be preventable, 44%. That ought to be 0. And that is really got to be the focus on the medical side. That's not saying there aren't other issues. I already talked about opioid problems. There are many others, which you've heard about in Herman's wonderful talk earlier. But we can do something about this 44%. The people in this room can fix that. Now, we've got a giant consortium in this state working on this. There's about 500 people who come to this meeting, but that's probably less than 1 in 10 people who are working on this. And you can see in the center of this is the State Department of Health and Human Services. And that is very, very important. But you can also see that there are a lot of other entities. So this is a very good example of a private-public consortium, and one that is based not on a few specialists, but on broad outreach and broad participation. And one of the things that we need to do is to make that even broader. The parts of Health and Human Services that are involved are the Bureau of Family Health Services, epidemiology, women, infants, and children, and maternal mortality surveillance group, which is made up of 2 committees. I have to say something about the committee, because that's been in business for a long time and provides the reviews and a lot with epidemiology, a lot of the clean data that what we need to do is based on. There are 2 actual committees. I chair the medical committee. Frank Anderson is my co-chair. And there's also an injury committee which focuses on injuries, drug-related deaths, suicides, homicides, things like that. The medical committee focuses on medical problems. So hypertension, hemorrhage, medical diseases, cardiac disease, blood clots, all that kind of thing. So there's 2 of those. We have worked very hard over the last 3 years to improve the functions of the committee. First, we have expanded the committee, and what we've tried to do is we were looking at cases that were 4 or 5 years old. You can't do anything about that, and you can't convince anybody it's important because, oh, well, we're practicing better now, which is probably not true. So we have worked very hard, and I hope that we'll be able to tell you next year we are pretty much up to date. And we've focused on improving quantity to start with, but we really want to improve quality, and that's what we're pushing for. And what we'd like to be able to do is to do it the way we used to do it and the way it's done in Britain to good effect, which is to actually be able to go out and talk to the doctors, the nurses, the hospitals, and the families. So we get a much better picture of what the problems were and how they interacted so that we can come up with having it not happen again that way. That's what the committee should be doing. You don't want to just look, you want to see if you can help fix the problem. We have had tremendous support from Health and Human Services, Lynette and Chris Fussman in particular. It's made a vast difference in how effective we are. We have Bob Lorenz helped create a pre-review so we can focus on the pregnancy-related deaths, and we are moving to the CDC record, so we will be able to compare much more effectively how we're doing with how other states are doing, and learn from them and have them learn from us, because this is a big national problem. So let me focus now. We started out with, in the middle there, with the HHS. Let me talk a little bit about what's going on the OB side, which is what I'm actually up here to do. We were, as Jody pointed out earlier, we were in the first 7 or 8 states that were invited to join AIM, National AIM. It is now much more extensive. We were invited because they used a figure that just was vital statistics, but we got lucky. I think it's not bad. I believe this is a real opportunity for us to improve health here in Michigan. And you can see we are now one of the more mature states. We've been in this business for 2.5, 3 years, and we have learned a lot. and there's still a lot more to learn. The goals are simple, and you've seen this before. We want to eliminate. Now, this is, it sounds good. It's what's called an aspirational goal. Do I think we're actually going to get there? Not in my lifetime. Now, that isn't so long, because if you think Herman's old, I'm ancient. But we want to eliminate pregnancy-related maternal deaths and severe morbidity, and as well as, importantly, disparity. They should not be happening. How are we organized to do this? This is probably not my most important slide, but surely my most boring slide. Well, you can read it as well as I can. We have an integrated program, and this is important. Maybe boring, but we have people here who focus on moms, and we have people here who focus on infants. And they are absolutely, intimately interrelated, and nobody that I'm aware of has ever tried to put this all together the way it should be before. And I believe that if we use the synergy that's available because of this, we're going to continue to do well and do even better. Most everybody who's involved with this are volunteers. There are some people from the State Department of Health and Human Services, but most of us are volunteers, and we couldn't do it otherwise because there is not nearly the funding that this deserves available. And it isn't that anybody's being bad. There's a lot of priorities in the world. So, but we have people who believe what we're doing is important, so we have a lot of volunteers. Importantly, and this hasn't been stressed enough, we could not start to do this without the involved organizations, in particular, Michigan Health and Hospital Association, because they had a data system in place that we could just tie into, and the first day I promised we wouldn't screw it up for them. We'd leave it intact and use it, and we have done that. ACOG, the Michigan section, has been tremendously supportive. AWAN, the nurse practitioners, the nurse midwives in particular. So all of these groups partnering with the HHS. We have just 2 committees. We have reorganized several times to try to make sure that we don't waste people's time, we don't have too many meetings, but we have enough meetings to keep things moving. And we have an overall steering committee, which is the more senior management tries to decide jointly on direction and important issues, and then the really important committee, the operations committee, chaired by Jody and Mary, and that's where the rubber hits the road. And those are the folks who are working with our hospitals, with our nurses, our docs, to try to improve care. And data is managed, both the transactional data is managed by MHA, and the outcome data is from vital statistics and epidemiology in the department. And we get them all together and it gets put in nationally. That's very important, and there's one point that needs to be made here, is we need to know how we're doing, but who really needs to know how we're doing is you need to know how you're doing. So we are just now, because National has only recently been able to deliver this, be able to give an individual hospital its data, which makes it really worthwhile to get it in, and give you relevant comparisons that are, you don't know who it is, but they're chosen so that you can see how you're doing versus similar institutions. And that is very important because that can help drive the process forward. It shows you where there's room for improvement. Here is a slide of our partners, and this isn't there because of money or anything. This is there because we couldn't do this otherwise. We couldn't do it without government. We can't do it without these organizations. Now, what we're doing is primarily, what you hear about are the safety bundles. And you've actually seen, at least the people in the maternal side saw this slide earlier in Jody's presentation. And basically, these aren't national protocols. They are guidelines as to what you ought to have in place to improve care. And they have been very carefully worked out and are used not only here in Michigan, but are used nationally. And depending on where your hospital is and what the exact situation is, you may do these differently, but this shows you the minimum you need. It gives you a uniform structure, and they're pretty easy to remember. Now, this shows you the patient safety bundles, and I'm going to show you the things that Michigan is involved with. The first, we chose 2 bundles to start with. And they were 2, if you remember the slide which showed you the major causes of pregnancy-related death, hemorrhage and hypertension were at the top of that list. So that's where we started. And that's what we've been asking hospitals to focus on and to do. There are others, but we thought that these were the 2 best ones for us to start with. Not every state has done it the same way. Now, in addition, the next thing is safe reduction in cesarean. We're not actually doing that. That's the OBI, the OB initiative. And those of you on the maternal side who went to those sessions today heard about this program. It is funded by Blue Cross. It runs out of the University of Michigan, Dan Morgan and his group. And they are using the AIM bundle, so it's consistent. Hospitals are working on that, but it is in very similar format, so we are hoping not to load too much on our providers and the hospitals so that you can focus and keep it sort of organized. So that's the next one. Here's some information about OBI, but I think this has been presented today, so I promised I've got 10 minutes left, and I wouldn't go over. What's next? Next is opioids. You've heard, we've got a big problem here in Michigan, and it goes across the state. Yes, we have plenty in the Upper Peninsula, and yes, we're seeing meth too, and yes, it's downtown Detroit. It's a big problem. We are not, for my aim, getting into that business. And the reason is the state has massive number of programs already, and you have to, with limited resources, you have to focus, and there's a lot being done already. We are taking a look at our data. It's in process right now. The data has been collected. We're in the middle of analyzing it, and we should be able to tell you what we have learned by this meeting next year. That's an important point. We will be back next year, and we're going to be even bigger and better. We've decided we're going to have to go up to maybe 1,000, room for 1,000 people, we hope. So these are the 2 we're doing. The OB initiative is doing the cesarean, low-risk cesarean project, and the department is doing opioids. We have one upstream solution. If you want to solve maternal mortality, you have to be pregnant. If you aren't pregnant, you cannot die of pregnancy. So spacing pregnancies is important, and there was a terrific presentation a couple of hours ago about the MICA program, also from based at U of M, but involving a group of hospitals. Are going to start out with a smaller group and then extend from there. And there is strong evidence that this can be very helpful to patients. I'm going to skip over that. Now, These are the data I was mentioning. Shows you how we're doing. I showed you up to 2016 before, and those are summarized in our baseline data from 2011 to 2015. And that shows you what was, and then we've looked at the last 2 quarters. We did this last year and presented it here. And this is now the last 2 quarters this year. I could have made it much more complicated so you couldn't see it by putting another couple of columns on, but decided not to. And the percent improvement is shown in the last column. It isn't wonderful, but it's sure as hell better. You cannot use a metric of mortality in a state because one case can change it. It's rare. It's too rare. But this is 100 times more common. So you can measure how we're doing with severe morbidity measures. These are CDC definitions used nationally. So we and other states have these data. So things are at least getting a little bit better. Well, where are we now? Well, we've been doing webinars. Frank Anderson told me today he'd just done one. They're terrific. We're getting pretty good mileage in those and a lot of people listening. I can certainly recommend them to you because it does help share information about important issues in maternal mortality and morbidity. This meeting is a tremendous amount of work. Before Nina and Amy, the Amy's did this, they were like in high school. They're a lot older now. There's a tremendous amount of work, and we have to thank them a lot. Coming together like this makes a tremendous difference. You look around and you see you're not alone. There are a lot of other people concerned about the same things that you are. And I think that we need to do this again, and I think it does make a big difference. You get to hear a talk like we heard just before my talk, and it should make you cry. That should not happen. We are going to be expanding. We've been doing some site visits. Now, Federico doesn't like that term, but we only do them when we're asked to come out and see if we can help. We have a group of people who do that and can go around, and we're looking at ways that individual hospitals can help their neighbors too. We need participation from more partners, and we're going to need to continue to work to get that. You saw we have a lot of partners. The more people, if we can keep it organized, given that we can keep it organized, the more people and the more groups who we have turned on by this and turned off by the problem, the better off we'll be and the better our interventions will be. And finally, while we already have, you've seen 5 things that we're working on or being worked on, which is a lot. It's more than most other states are trying to do. We really need to increase, to keep focus, but increase the breadth of what we're doing. And clearly, you heard today, we're going to need to do some work on disparity, very specifically, across the projects, the programs and problems we're looking at, but also as an individual bundle. It exists. We are going to need to take a look at that and see what we can do to deal with that problem here in Michigan. So I think that I don't know what that is there for. Is that your first slide, Amy?
It is.
Let me turn it over to Amy. And I actually finished a minute early. Thank you.
Thank you, Dr. Sokol. We should have given him a transition slide. A lot of my slides you've already seen, so we're going to speed through those, and then I'm going to make a couple of pleas, some mine and some other folks have given me to remind you about before the end of the day. But I'm Amy Zagman. I'm with the Michigan Council for Maternal and Child Health, and we do advocacy and on policy and legislation at the state level, hopefully to support all of the good work that all of you do. Many of you I know, and many of you I'm anxious to meet and talk with just to find out how we can work to get policy and regulation either out of your way or into your lives, whatever would make you more successful with outcomes. So I do have a couple of slides just to follow up on Dr. Sokol's comments about how all of these things work together. You've already heard today about the Maternal Infant Strategy Group, been introduced to them. I guess what I'd like to say is my participation on this group really has taught me that this is a group of people who really want to listen. They come not only with their own expertise, but they want to hear from all of you regularly about what some of those barriers and obstacles are, what you think is needed and necessary to deal with infant and maternal mortality in the state. So I hope you've had a chance to meet folks, or you will tomorrow, and I just encourage you to do that. The names are here, and many of the organizations that they represent are here, so if you don't get a chance to connect with folks here in this day and a half, I hope you'll seek us out otherwise, and know that we're meeting regularly really to talk about moving forward with the plan that was also mentioned. I think Nina tried to, at the end of our lunch session, just mention that, especially because there is so much conversation going on here at this meeting, that we want to make sure that folks feel like they've had adequate time to really review the Mother-Infant Health and Equity Improvement Plan and make comment to it. She sent out an email as part of the app. So if you have comments, I think if you could get those comments back by close of business Wednesday, our Maternal Infant Strategy Group is meeting on Friday, and I think we'd like to really review the comments that have been submitted thus far. So I encourage you to do that. The plan really, hopefully you have already participated in the town halls last summer or the collaborative meetings and had some input into the plan. I guess what I want to say, coming from the council's perspective, is we have to all find ourselves in this plan, right? We have to find our role and find our expertise. And I really want to impress upon you not specific bill numbers today or specific policies. We've had some wins in the last couple of years really to support a lot of the efforts. You know, we had a couple of big announcements last year, right? We got dental for pregnant women in a way that we haven't had before. Medicaid coverage for, got women out of fee-for-service, got them into managed care. I'm hoping that many of you are starting to make those referrals and starting to see increased access to oral health care, which we know is an important part of overall health for pregnant women. Change in Medicaid policy last year around the LARC insertion immediately postpartum, which obviously leads into all of the work that's going on now with MICA or MICA, however I'm supposed to say it, and now all the implementation work that's happening. Those are examples of getting policy on the books, out of the way, so all of you can do the work. I think there have been legislative wins. We now have mandated maternal death reporting in the state, which we were not always sure we were getting all of the maternal deaths reported. To Dr. Sokol's point about the review, that's really critically important. I think just as important is just overall education. So to Ms. Irving's point about leaders that want to act, I find leaders every day at the Capitol who may want to act, but they're not very informed. They need to hear from you and your communities. So I guess I would hope that on top of you finding yourself in the plan and your own expertise, that every one of you feel some responsibility a little bit to wear the policy and advocacy hat. I think those of us who that is our line of work every day try very hard to be judicious in the time that we ask from you to engage in that process. And so hopefully, whether it's through my organization or your own professional organization or the hospital association, you're seeing those opportunities to be engaged with your elected officials or answer a call for public comment to a Medicaid policy. But absolutely that is important. It's one thing for those of us who it's our job every day to lobby on those things. It's completely different for a lawmaker to sit down with you at a coffee hour and hear how important it is for the everyday work that you do for the real families and their constituents that you touch every day, to see certain bills pass or see certain resources in the state budget. The governor's proposed budget just came out, and we're in the process of reviewing it. I think it was hugely important that she was here today to be supportive of our efforts. We need to see that followed up with resources. So not just the resources that are already in the state budget, but additional resources in the form of reimbursement, in the form of investment in public health, which we know has been seriously disinvested in over the years. So, you know, again, when those opportunities come, when those, you know, advocacy messages go out, please don't think that you're not the right messenger. You're absolutely the right messenger. And if you're not comfortable with those things, hopefully, again, those of us who that's our line of work are offering you not only opportunities, but the tools to do so. So my staff was out today with a table in the vendor area, and maybe some of you signed up for our Friday notes. If you didn't and you want to, it's free of charge. We send out a weekly e-newsletter and try to highlight those opportunities. We also had some infographics out that you know, are sort of the way in which you have to learn to talk to folks who aren't in the weeds every day, right? These are lawmakers who have lots of issues thrown at them. So it's really important, I think, that we have cohesive, coordinated messages, and we do a lot of our advocacy work in partnership with some of the other organizations that I mentioned, but we really, really need those of you on the ground to take these opportunities. I can sense how tired everyone is. I'm standing in the way of the end of the day. I'm actually at least standing in the way of the awards that I know we're all anxious to see how many hospitals are receiving awards today, but I'll just say this. Dr. Hassan started the day. She and I co-chair what is now the Mother-Infant Health and Equity Collaborative. Used to be where we talked specifically about infant mortality, but we're trying to talk more cohesively about all of the work that's going on in the perinatal regional collaboratives and talk about that from a state perspective. I think those meetings have been hugely interactive and engaging, and I hope if you haven't had a chance to come that you do. The next meeting is in Detroit on May 9th, and I hope that you will consider joining us, not only at the larger statewide meeting, but I also hope that you are participating in your local perinatal collaboratives. This is really, I think, where the conversation happens. And I love to come and listen to those conversations because I'm listening with a completely different set of ears. So what you all present as barriers, I'm trying to think of how can we get money to get that out of your way? How can we change policy to get that out of your way? And so I just love to come and be, you know, a little eavesdropper. So call to action. I think you already heard from Dr. Sokol about connecting with the OB initiatives. I think that's incumbent upon you, whether you're actually at the hospital level trying to implement them or whether you're trying to help prepare a woman before she even goes to the hospital to understand what might be in store for her if she ends up with complications. I hope that you attend the improvement planned community of practice. There are webinars, so you don't even have to leave your office. You don't have to go to one of these perinatal meetings, collaborative meetings. You don't have to come to the statewide meeting. There are webinars to actually involve you and include you in the improvement plan. I hope that you're taking advantage the operations committee for My AIM for the OB initiatives webinars every month. That I think are hugely helpful for those of you who are trying to move those initiatives forwards. And again, I hope that you will join us at one of these MyHEC meetings. Again, the next one is in Detroit on May 9th. I promised Nina I would mention that you can have input on the plan, and I hope you do that. Again, the email is in the app. And I also promised Dr. Flora that I would mention a couple of things about the online evaluation that you're going to receive after this. So McLaren, that's offering continuing education credits for this session, is also trying to get their interprofessional CE accreditation. And so even for those of you who may not have been eligible today, if you were to answer the online evaluation and give your professional designation, that will help McLaren be able to get that interprofessional accreditation, which could be hugely helpful going forward. The MIHIC meetings that I mentioned do have CE attached to them. So again, your answering this will help, I think, in the future with being able to offer CE for those MIHIC meetings. I'll just mention too, a reminder for the MDs and DOs in the audience today, that participation in MIAM or those MIHIC meetings that I just mentioned count for your maintenance of certification. So knowing that that's hugely important, there's information about that on the MyAIM website if you're looking for it, or you can talk to Dr. Flora, he's right here in the front. I think that's all I have. I know we don't really have time for questions, but I'm kind of obvious today in my bright green jacket. So if you want to talk policy with me, I'll be here for a little while afterwards. And if you didn't get a chance to sign up for our Friday notes and you're super interested now in being involved in policy and advocacy, please give me your card and we'll get you added to our e-newsletter list. And I think I'm going to give it back over to Dr. Sokol for the award.